Hello, everyone. Well, it is right on time, and so we are going to uh, we're just going to get started on time today, just so we can make sure that we utilize the right amount of time and get everyone out of here on time as well. So I'm Elizabeth Skoy. I'm a professor at North Dakota State University, also the director of the CAP Center. I'm able to see those that are getting admitted right now, and I recognize a lot of names, and so it's great to have everyone joining us tonight. This has really been kind of a request by quite a few individuals from the pharmacy community for some education related to RSV vaccines. And so we're going to be providing this today. Thanks to a lot of you who have filled out a survey that was sent out from the CAP Center earlier this in the fall semester or this past fall. I really appreciate people who filled that out. And a lot of that feedback was that more education or some structured education on RSV vaccine was needed. And so that is what we're doing today. We are going to be just some housekeeping things. Everyone is going to be muted. This particular education, although it is targeted and developed for pharmacy, we have pharmacist and pharmacy technician CE for this. Although that we have that, this has been made available to a wide variety of other healthcare professionals through the North Dakota Department of Health and Human Services. And so because of that, and because we didn't know of how many people would actually be joining us tonight, we were expecting a little bit of a larger crowd. We are going to have everyone muted the entire time, and then also only utilizing the chat function for Q&A. And so at the end of the day, so at any time, feel free to put any questions that you have in the chat. Time permitting, I'll be answering hopefully all of those or as many as I possibly can in the allotted time. So yes, at any time, go ahead, put those questions in the chat. We'll answer those at the end. So we're going to go ahead and get started. Also, since we are recording this, I am going to be turning my my camera off because we're going to be utilizing this for recorded CE as well. Okay, so as I previously mentioned, my name is Elizabeth Skoy, and I do not have any relevant financial relationships or potential conflicts of interest to disclose. And also the funding for this CE presentation has been provided from an indirect grant from the CDC. Also, just to note that I do serve as the pharmacy representative from the American Pharmacists Association on the ACIP work group for adult RSV vaccine. And so although I do serve on that work group, anything that is discussed in that work group is not available for public knowledge. It's actually confidential until it goes to the large wide of the ACIP large public meeting. And so if anyone has any questions particular about anything that's discussed in those work group meetings, I'm not allowed to disclose those. So our learning objectives today for the pharmacists are to describe the pathophysiology of the respiratory syncytial virus or RSV, compare and contrast between commercially available RSV vaccines, identify patients eligible to receive the RSV vaccine, and then summarize how to recommend, prepare, and deliver the RSV vaccine to eligible patients. Our technician, pharmacy technician, we also have objectives for pharmacy technician CE today. So for that is to describe the pathophysiology of, again, the RSV virus, compare and contrast between commercially available RSV vaccines, explain pharmacy's role in the provision of RSV vaccine, and then summarize how to prepare and deliver the RSV vaccine to eligible patients. So first, we're just going to go through some basic pathophysiology of the respiratory syncytial virus, or RSV, as we already called it. And so RSV is a respiratory virus, and it's highly contagious. And so it is spread through droplets, so similar to like influenza or COVID-19. So thinking of sneezing, coughing, kissing, or touching a contaminated surface. And that's particularly if you touch a contaminated surface and then, wash your face before you wash your hands. That's another way to get that. And the virus can actually live on hard surfaces for hours. So it is a highly contagious virus. And not only is it just because of the way and easy how it's spread, but also that individuals once they have the virus, they're actually contagious 2 to 3 days, typically prior before symptoms even occur, and then 3 to 8 days after symptoms are resolved. And so again, thinking of how easily this can be spread. The epidemiology for the virus itself. So what are the symptoms? Very similar to a common cold. So runny nose, sneezing, coughing, fever. Those are the typical symptoms of RSV. And most of the time, there really just is supportive treatment for RSV. So, typically it's rest, hydration, and then, of course, trying to avoid spreading the virus to others as much as possible. And then the thing with this particular virus is that there can be some complications from that. And so pneumonia and bronchiolitis are the two more common complications of RSV. Bronchiolitis is inflammation of the small airways. And it's actually RSV is the most common cause of pneumonia and bronchiolitis in infants less than 1 year of age. And this particular virus, for the most part, people are going to, healthy adults and children will typically recover without incident. However, this virus can be very dangerous to the infants and elderly. So the very young and the very old are the individuals that will have the greatest effects from this particular virus. So let's look at our public health impact from children. Typically, when we think of RSV, we think of infants, right? And so that's typically where, when we've talked about RSV in the past, we've really talked about the very young and the infants. And if any of us are, parents on the call, probably have had experience with either our own children with RSV or specifically in pharmacy settings with children with RSV as well. And so we're looking at particularly the public health impact. These numbers are reflecting children less than 5 years of age. And so for hospitalizations, it's estimated, this is from the CDC, it's estimated for hospitalizations to be 58,000 to 80,000 individuals annually, and approximately 2.1 million clinic or outpatient visits annually, and 100 to 300 individuals and deaths annually from RSV. Again, this is children less than 5. Those that are at high risk are particularly premature infants, infants or young children that have lung disease, heart disease, and then also there could be other potential risk factors are individuals obviously with weakened immune systems, or if there's some neuromuscular disease, because those individuals will have difficulty clearing the secretions and so can lead to complications. One thing to note, we're going to get to the adults here in just a moment, but these numbers, the hospitalizations and the clinic outpatient visits, these are potentially drastically underrepresented, mainly because there's not a lot of widespread testing for RSV. So particularly the CLIA wave tests vary very much in sensitivity and specificity, and even there's a lot of varying sensitivity for diagnostic tests for RSV. So when you look at the quality of tests for RSV, coupled with the fact that there really isn't a treatment for, direct treatment. There's not like a test to treat like you would see for something like, influenza or strep or something like that. So because of that, these numbers are estimated to be underrepresented to the actual burden of disease for RSV. Then looking at the public health impact for adults, particularly we're looking at adults greater than 65 years of age. And looking at these numbers, I know the first time that I saw these numbers, I thought it was pretty interesting because, again, we think so many times about RSV in infants and children, but if you actually look at the number of hospitalizations, so the number of hospitalizations, are quite high, 60 to 160,000 annually, but the death estimates are actually higher than they are for infants and children less than 5. And again, our high risk for adults are a little bit different. You still have the individuals that might have a neuromuscular underlying condition or might have some immunosuppression, but particularly high risk for RSV are adults with diabetes, lung disease, and cardiovascular disease. So those are kind of our big ones when we think about high risk for RSV in adults greater than 65. So another thing to just consider is the fact that RSV is a seasonal virus. And following these numbers historically, so what we've seen. So if you look in the 2018, 19, 2000 1920, so those are the kind of the red X lines and then the like purple dot lines there. And so typically this virus kind of has a normal peak in about January, so that's where we saw historically. Then 2021, obviously we had the pandemic, people were masking, people were staying home, and so we really didn't even see a peak, maybe a tiny peak around August, but really really low during that season. Back now, then in 21, 22, you kind of saw a little bit more of a normal redistribution where we kind of saw it picking back up again around December. But last year, that 2022, 2023 season, we saw that back to that, what we call like that normal distribution, but really high numbers. So it actually peaked earlier. It peaked in November, and we had a lot of high cases, a lot of numbers of hospitalization rate last year. And you probably heard last year's season of the triple threat, like the influenza, the RSV, and the COVID-19. That's where we can kind of see the picture of where RSV played in that. So now talking about, how we can potentially prevent severe disease. So we're first going to talk about, children, and then we're going to go on to adults. And so for children, so there is a monoclonal antibody, and the most common right now, and the one that's utilized is nirsevimab. So nirsevimab, or the monoclonal antibody, is not a treatment; it's just an added extra layer of protection. And then more recently, one of the RSV vaccines that we're going to be discussing tonight, Abrysvo, which is manufactured by Pfizer, that one has now been approved from the ACIP to give to a pregnant mother. And this is actually the first vaccine that's like the primary and only really reason to give it is not only to necessarily only protect mom, but it's actually to protect baby. And so this is the first vaccine that's really the only reason and indication for it is to give to mom to protect the unborn baby. And so that is Abrysvo. Then also kind of going to our other two vaccines that are available is for adults now 60 years and older, is Abrysvo and RXV. And so those are the two commercially available RSV vaccines. And we're going to be primarily talking about those. We're going to touch a little bit on vaccine and pregnancy tonight, but we're actually, the North Dakota Department of Health and Human Services is going to be putting on a separate continuing education for the role of RSV vaccine in pregnancy. So we're not going to touch too much on that today. We're actually going to focus a little more heavily on the adult side. So looking at our vaccine overview, so both RSV vaccines are a viral subunit vaccine. So as a reminder for what that is, the manufacturing process, they use part of the virus that will then target or trigger an immune response. We have quite other vaccines that are viral subunit vaccines. Examples are like HPV vaccine, pneumonia, shingles is another, our current shingles vaccine is another example. So these vaccines are great because you can typically give them with someone with a decreased immune system, because they'll actually still warrant or give an immune system response, even if they have a decreased immune system themselves. On the other side of that is that sometimes to get the immune system response you might need an adjuvant in there. And then other times, some of these vaccines might need a booster as well. So both vaccines have been approved and recommended by the ACIP for adults 60 years and older. And really important to really stress this, there's been some reports of errors across the country and in North Dakota where the vaccine has been given to infants, and there is not an approved RSV vaccine for infants right now. The only RSV vaccines that we have are for adults. It's either pregnant women or it is for adults 60 years and older. So just to make that really clear and make sure that we really stress that. And so, again, we talked a little bit that one of the vaccines, Abrysvo, is also approved for pregnant women. And then also the RSV vaccine, the one that's manufactured by GSK, that does have an adjuvant, and GSK also manufactures Shingrix, or the shingles vaccine. And the same adjuvant that is in the shingles vaccine is actually in RXV. And they use the exact same adjuvant, but they use half the dose of adjuvant in RXV as they do the Shingrix vaccine. And both vaccines are given at a dose of 0.5 milliliters, and they're both given intramuscularly. So now we're going to talk about each of these vaccines. We're going to break them down into the data that was presented to the ACIP, and then in the public meeting as they made their recommendations. And this is the clinical trial data. We're going to go through the efficacy as well as the safety profile of both of these vaccines. So we're going to start with Abrysvo. Again, Abrysvo is the vaccine that's manufactured by Pfizer. And we're going to just kind of go through the efficacy. So the clinical trials for both vaccines, Abrysvo and RSV, looked really at the same criteria. So it's really nice for us to be able to compare those. And so for outcomes, they looked at lower respiratory tract disease. So if you look in column 1, you're going to see kind of this this lower respiratory, kind of circle it here, this lower respiratory tract disease. And that's what they were looking at. And so for season 1, you can see that when they looked at lower respiratory tract disease, they had the vaccine efficacy. So it was 88.9% efficacious for season 1. Okay. And then season 2, also you saw a little bit of a dip there, but it still had high efficacy for RSV associated lower respiratory tract disease. And when they looked at lower respiratory tract disease for the clinical trials, they looked at worsening respiratory signs or worsening cough. They looked at sputum production, wheezing, shortness of breath, and rapid breathing. And so those were the types of things that they looked for that lower respiratory tract disease. Then when they looked at the RSV associated medically attended lower respiratory tract disease, that was in other outcomes. So they looked at the presence of disease, and then they looked at did the vaccine prevent medically attended RSV? And for medically attended, they really had to lump everything together because the trial was not powered high enough to be able to show estimated efficacy specifically against hospitalization and death. And so they had to look at really what the medically attended lower respiratory tract disease and kind of lump that together. And so that was any RSV that prompted any healthcare visit. So any outpatient visit, such as hospitalization, emergency department visit, urgent care, telehealth, office visit, pulmonologist, primary care, pretty much anything that would require medical attention is what they looked at. And there again, in season 1, you did see that efficacy of 84.6%. Again, and high efficacy for the vaccine itself. Vaccine, or for the season 2, you'll notice that is missing. They couldn't look at season 2 independently just because that was unable to power just season 2 itself because there was the lack of numbers in the southern hemisphere. And so really they had to look at season 1 and then take what they could from season 2 to get it combined, but they couldn't look at season 2 independently. But the overall takeaway is that, again, when they looked at the clinical studies at the time, they were not able to have a power representation to show prevention of hospitalization and death, but they did show efficacy against lower respiratory tract disease and then medically attended lower respiratory tract disease. So now we'll talk about the safety of Abrysvo. And so they looked particularly at serious adverse events. And so this was really serious adverse events was anything that was, would have resulted in death, life-threatening, required hospitalization, or had any disability or anything like that. And so if you look at the RSV, so the individuals that received the RSV for serious adverse event and placebo, it was not statistically different. Okay. Now you might look at these numbers and say, holy cow, 792 and 749 in the placebo. But do remember that they were studying individuals at a higher age. And so when you're looking at individuals with 60 and older for the clinical trials, that you're going to see, potentially just some overall, hospitalization, death, those types of things in both groups. But when comparing the two groups, there was no statistically significant difference. And then same thing when you looked at reactogenicity events. So looking that what they looked for there was like pain at injection site, redness, swelling, any systemic reaction, like maybe myalgia, fatigue, seizure, muscle pain, which I already said, vomiting, diarrhea. So any of those like overall systemic events, and that they only looked at that 0 to 7 days following vaccination. And again, looking at the two groups, RSV versus placebo, you did not see a statistically significant difference. So there really wasn't any difference between those two. Now, one thing that is to note is that 3 individuals in the RSV group, and that's mentioned right here, there were 3 inflammatory neurologic events in the RSV group, and there was 0 in the placebo group. And so this is something, those events, looked at Guillain-Barré syndrome, Miller-Fisher, which is like another type of Guillain-Barré. And so looking at that, we'll talk about that here in a minute, but it is important to note, and that was really clear in the MMWR that was published in the ACIP meeting that they did identify that. So now looking at, so for RSV, also, we're going to talk about those same things. So the 2 studies actually really looked almost at identical outcomes. And so I'm not going to repeat, lower respiratory tract disease, what that is, and medically attended, because they looked at basically the same outcomes as Abrysvo did. So for the RSV vaccine, again, season 1, you had an 82% efficacy. And then for RSV associated lower respiratory tract disease, and then an 87.5 efficacy for medically attended lower respiratory tract disease. Season 2, you saw a little bit of a dip at that 56.1, still giving you efficacy, but just not as high as season 1 for lower respiratory tract. They were not able again to power season 2 to look at medically attended lower respiratory tract disease independently, but they were able to combine the 2 seasons to look at overall efficacy between the 2 seasons. And then also just to note, they have looked a little bit at, they did do one study that was presented to the ACIP for looking at potentially a booster at season 2. It didn't get the numbers back to where you were at season 1. And so at this time, a booster is not recommended, but that might change, and things that they're following as they continue to monitor the vaccine and efficacy, and clinical trials of these are ongoing. So looking at safety data for RSV, again, you're going to see the serious adverse events in both groups were not statistically significantly different. So no difference between placebo and vaccine. However, you did see a statistically significant difference for severe reactogenicity events. And so you did see a statistically higher number in the vaccine group versus placebo for RSV. Now, do remember that RSV is the vaccine that does have that adjuvant, and as we know, kind of what adjuvants do and their potential side effects, helps explain as to why that is. And it was in almost about 4% of individuals did experience that in the clinical trial. And then one other thing to note: this group too had 3 events that were reported for the inflammatory neurological events. And so again, this was across all trials, but they did have 3 compared with 0 in the placebo. And so they did make note of that. So just something to also consider. They also had, when they looked at severe adverse events in the RSV group, they did have some individuals that had atrial fibrillation. new onset, and that was they had 10 in the RSV group and they had four in the placebo group. So that was another thing that they're continuing to monitor as well. Cannot be caught, there's not enough numbers there to say specifically related to the vaccine, but it's just something they may note of in the clinical trials, and they're following us off post-marketing safety data. So all of this information was reported to the ACIP as along with the work group recommendation. And ACIP recommended that adults equal to or greater than age 60 years old and older may receive a single dose of RSV vaccine using shared clinical decision-making. So that is the overall ACIP recommendation at this time. Now that can change. There could be another reexamination of new data that comes out, and potentially the ACIP could vote to change that at a future time. But right now, for this year and at this time, the recommendation is any adult equal to or greater than 60 years and older may receive a single dose of RSV vaccine using shared clinical decision-making. This was an interesting and unique recommendation because this is the first vaccine that is only clinical decision-making. Now, we've heard of clinical decision-making before. It's been associated with other vaccines as part of a discussion with our patients, but they usually, those other vaccines, like for instance, HPV vaccine, have other recommendations, like strong recommendations and blanket recommendations for other age groups or risk factors. But this is the first vaccine that is 100% clinical decision-making. So what does that mean? So let's talk about clinical decision-making here. So clinical decision-making, so what is clinical decision-making? It does not target all individuals in an age group. So it is not all individuals 60 years and older should get a vaccine. It is not all children greater than 1. It's not a blanket target all individuals in an age group. It does not do that. It does not target all individuals with a specific risk. So we have other vaccines that do that. However, there is, you really have to consider the patient's individual risk for severe disease. And that is a decision made in collaboration between the healthcare provider and the patient. So you and the patient come together and you look at that patient's individual risk. Of course, for this particular vaccine, they have to be greater than 60 years of age, but then you go ahead and you make that recommendation. So again, diving a little bit deeper into shared clinical decision-making. So shared clinical decision-making is, per the CDC, defines what is a healthcare provider? We said in the previous slide that it's between the patient and their healthcare provider. Well, the CDC defines healthcare provider as anyone who provides or administers vaccines. So that can be a primary care physician, a specialist, a physician assistant, a nurse practitioner, registered nurse, and pharmacist. So let's not forget, again, we're really targeting pharmacy and pharmacy continuing education in this session. And so really important to realize that pharmacists have the same amount of ability to recommend and have that conversation with our patient as any other healthcare provider. So just recognizing that. So our high risk adults. So looking at, if we have to do shared clinical decision-making with individuals 60 years and older, well, then we need that shared clinical decision-making, we have to take into account their risk. What is their risk factor? And so the chronic medical conditions that have the highest risk factor for complications for RSV are lung disease. Of course, RSV, lung disease, think that. So this is asthma or COPD are examples there. Any cardiovascular disease itself, so congestive heart failure and coronary artery disease are the two cardiovascular diseases that are most closely associated with RSV complications. So it's not just like plain hypertension. We're looking at more like that overall cardiovascular disease. And then diabetes is the other 3. So if you think of the number of our patients 60 and older that we serve in just that chronic disease group, there's quite a few, right? Anyone that's immunocompromised, I do have an asterisk there because there were no individuals that were immunocompromised in the clinical trials. You can imagine that would be a complete disaster for vaccine manufacturers to, target immunocompromised. So although there were individuals that were, there were no individuals that was an exclusion criteria for the vaccine itself. However, it is recommended just because of kind of common sense that individuals that are immunocompromised would be a candidate for RSV vaccine. Again, if they're 60 years or older. Neuromuscular conditions, as we mentioned before, difficulty clearing secretions, liver disease, kidney disease, or other ones. And then anyone that is frail is also at high risk. So thinking of individuals of advanced age or individuals that are in long-term care facility. So I'm going to talk briefly to you about providing RSV vaccine in North Dakota. And so we have currently a statewide protocol in North Dakota where pharmacists can recommend and prescribe any ACIP recommended or CDC recommended vaccine. So you do not need a prescription. You can be the provider or the prescriber of that vaccine in North Dakota. So you don't have to go out and search for a protocol. You don't have to go and find a collaborative practice agreement. North Dakota, we have a statewide protocol for all vaccines for pharmacists. Okay. Also, recognizing that if you are the provider under that RSV vaccine, when you prescribe that, you need to have an MPI number. I think almost all pharmacists in North Dakota do, but just to keep that in mind. Of course, report that to the North Dakota Immunization Information System, or NDIS. Again, that's a requirement in our protocol. So making sure you're reporting that so other healthcare providers know and can have documentation that that patient received the vaccine. And then also know that if you are prescribing under Medicaid, so if you have a patient that is 60 years or older and they have Medicaid, you do need to have a Medicaid provider number if you're going to be the prescribing healthcare provider on that. Now, we've already done some webinars in the CAP Center of how to get registered under Medicaid as a provider. So if you have any questions on that, please reach out to that. Reach out to us on that. We'll be happy to get you the webinar. We have a recorded webinar on that as well as a how-to guide. So keep that in mind as well. And then kind of another role is just identifying patients and making the recommendation. We're hopefully winding down a little bit now for vaccine. I know the influenza in October, vaccination for influenza and COVID was really crazy. I know we're still doing that even into November and early December. But I can't even tell the number of patients that when I was vaccinating for like influenza or COVID, they all fill out the vaccine screening questionnaire. And a lot of our questionnaires have that question of, do you have diabetes or, chronic lung disease? We ask particular questions on a question about that. And if a patient answered yes, I would ask, I'd say, you marked yes on this. What is that can you tell me a little bit more about that? And they'd be like, oh, I have diabetes, or, oh, I have COPD, or I have asthma, or whatever it might be. So that's an open gate for you to have that conversation with them if they're 60 years and older, if it's something that they have considered, if they've considered the RSV vaccine or not. I don't think I had one person that I had the conversation with that was not interested. That was, some had heard of it, some hadn't even heard of it. We had the conversation. I didn't have a single person, if they were in there for their COVID vaccine or their flu vaccine and they were 60 and older, that said, nope, I'm not interested in that. So again, those are individuals that were at higher risk that was targeting. And then also recognizing that we have that weird age range, right? So this is a Medicare Part D covered vaccine. And so you're going to that 60 to 64, right? You're going to be covered under that private insurance if they have it. And then Medicare at 65 and older. And so Medicare, you're going to have that full coverage now. You're going to have like that zero copay for those patients, but recognizing that private insurance is going to play into the individuals that are less than 65. Also, because this is a Medicare Part D vaccine, we've heard from individuals nationally, from my national calls that I've been on related to this vaccine, as well as locally within our state, that clinics are not carrying the vaccine because it is a Medicare Part D vaccine. And so pharmacy really encouraging pharmacy to stock this vaccine and being prepared to administer this vaccine, especially if our clinics are not carrying it. You can co-administer this vaccine with other vaccines. There was a study with RSV did a study as part of kind of an arm or spinoff of their clinical trials of co-administration with the adjuvanted influenza vaccine, as well as Shingrix with those adjuvants. And there was the outcome of that was yes, you can co-administer with other vaccines. And then of course, just recognizing in North Dakota that certified pharmacy technicians who have undergone the proper training and are being overseen by a pharmacist that can provide immunizations, that they can also provide that immunization. So just being aware of that. I do have the visual here in the corner of administering more than one injection. So if you think of the season we're in right now, someone might be getting, a COVID-19 vaccine, they might be getting an influenza vaccine, and they might also be getting an RSV vaccine. And so looking at proper administration technique, we're just always remembering, of course, wanted in the deltoid, avoiding that low upper third of the deltoid. And also, if you have more than one intramuscular injection, you want to separate them by at least an inch. If you are utilizing an RSV vaccine that has, especially if the vaccine that has the adjuvant, I would recommend separating the two from the COVID-19 vaccine and adjuvant, because that's best practice. If you have a vaccine that's going to cause more of a local reaction, you might want to separate them in separate limbs. So if the patient is up for that, would consider doing those in two separate limbs. So storage and handling of the vaccine, both of these vaccines are stored in the refrigerator, right? So I think we've had other vaccines, obviously, that have had some like freezer temperatures or ultra freezer. That is not the case with this vaccine. It is a refrigerator vaccine. Again, that dose route is 0.5 milliliters IM. A couple of things just to consider. So the Brisvo vaccine, again, which is available through Pfizer, that one has to be used within 4 hours of reconstitution at room temperature. And after reconstitution is stored at room temperature for 4 hours. This vaccine has a vial adapter. And to my knowledge, this is the first vaccine that's had a vial adapter with it. So just to be aware, when you open up that vaccine, it can be an expensive vaccine. So make sure that you read through the package insert, and vial adapter is incredibly easy to use, as with any other regular drawing up vaccine. It's not like it's hard, but just making sure that you do read through that. There's some videos on how to utilize the vial adapter too. So just recognizing that it has there. So it has a vial adapter and sterile water in a pre-filled syringe. So really to reconstitute it, you put in the vial adapter into the vial of the vaccine powder, and then you attach the pre-filled syringe that has the sterile water in there, and then you reconstitute it, and then you remove the vial adapter, or you attach a needle to the pre-filled syringe after filling it back up. So it's kind of how that works. For RSV, that vaccine, again, has to be used within 4 hours of reconstitution. It can be at room temperature or refrigeration. And this is the classic. It has the adjuvant in the vial. So whereas the Brisvo has sterile water and a pre-filled syringe of the powder, RSV is going to have the powder and that has an adjuvant in the vial. So you need to drop the adjuvant and then reconstitute. Just one note here, that anytime we have a reconstitution, just remembering that ACIP does not recommend changing the needle in between drawing up and administering. And so I've seen this quite a bit out in practice. And so just remembering that ACIP CDC recommends against changing a needle that one time through the puncturing of the needle through the actual vial top is not going to dull it to the point where you cannot administer a vaccine. So really with this, just making sure that when you draw up the vaccine, that you reconstitute it with the needle back into the vaccine vial before you pull that back up. But again, stressing not to, recommended to not change needles in between drawing up vaccine and administering vaccine. So for RSV vaccine in pregnancy, again, we're really going to touch on this briefly because this is really focused more towards older adults. However, I will say that I think pharmacy is playing a bigger role in just because we have some clinics across the clinics and hospitals that aren't necessarily stocking the vaccine because it is that Medicare Part D vaccine. So your patients might be coming to you, or pregnant patients might be coming to you for vaccination. So verifying that the patient is 32 to 36 weeks gestation and that you should be giving it to pregnant persons between September and January. So obviously we're in December right now. So December through January is the time that you would be giving it to pregnant women 32 to 36 weeks gestation. So that is the time frame to give that to them. Efficacy for this vaccine. So when given to pregnant women between 32 to 36 weeks gestation, there was a reduced infant hospitalization by 68% and clinical visits by 57% at 3 months. And then also reduced infant hospitalization by 57% and clinic by 51%. Also with this particular adverse events with that vaccine, so for pregnancy, the vaccine group had 16.2% versus 15.2% for pregnancy for the vaccine. With the preterm birth, you had the vaccine group at 5.7% and placebo at 4.7%. So a tiny bit higher, but it's actually not statistically significant. So I know there's been some discussion on potential preterm birth with the RSV vaccine. That's why they decreased the gestational age between 32 to 36 weeks. And really, there wasn't a statistically significant difference between the vaccine and the placebo group. Okay, so we are going to get to a quick case study here, and we'll get to some Q&A as well. So Sue is a 66-year-old female who presents to the pharmacy for her influenza vaccine. And upon review of her NDIS profile, you identify that she is due for COVID-19 and an influenza vaccine. She is currently taking medications for diabetes and hypertension. Will you talk to Sue about the RSV vaccine today? Just give you a moment to think about that. And so the answer to that one is yes, you would. Mainly because Sue is obviously greater than or equal to 60. She's 66 years old. And also she does have diabetes. So this would be a person that you would want to potentially have that conversation with. So before we get to the CE code, we'll look at see if there's any questions. Feel free to throw those into the chat and I can review those. But here, if anyone has any questions. As people are typing, just to also note that we also just to note that again, there is going to be another continuing education opportunity available for the RSV vaccine in pregnancy. So be looking for that. Also, the North Dakota Department of Health and Human Services has been putting out some other resources that are available, like prescription pads for pharmacies, as well as providers to give to pharmacies or as a referral to pharmacy. So you might be seeing those too from providers as well as pharmacies. You can utilize those if you want to utilize a prescription, particularly for the RSV vaccine. And really just a couple other things we've heard, again, just error reporting kind of on a national level, but that there's been some administration of RSV in pregnant women, and just remembering that RSV is actually not approved for pregnant women. It's only Abrysvo. So RSV and Abrysvo are both equally approved for individuals 60 years and older, but the only Abrysvo is approved for pregnant women. So we had one kind of question out to everybody, and you can put in the chat too, but originally we heard a little difficulty about RSV vaccine available to pharmacies to order. So kind of earlier on when we were doing this, we were hearing some reports of difficulty getting the vaccine. So if you've have any concerns with that, by all means, please let us know. And we'd like to know, or you can even, utilize the chat function and let us know if there's been any concerns with obtaining the either RSV vaccines. So here we're going to, I think what we'll do is we'll stop the recording and then we will show our